At the start of this day too, I would like to again pay respects to the traditional owners of the land on which we meet, the Ngunnawal people. Pay my respects to their elders, past elders, present elders, probably most important of all, future elders. And pay my respects to this land, which has never been ceded and never will be ceded. And I'd also like to acknowledge any Aboriginal and Torres Strait Islander people here today. Busy day yesterday, yoga sessions, lots of parallel sessions. We had Adam Coltsow's brilliant interview with the former minister, Greg Hunt, and again 3 parallel events last night across this town, painting the town literally red. Again, this conference is breaking registration records, which is fantastic. Just a little bit of housekeeping. We've had a request from the Convention Centre. If you're first into the exhibition hall during catering breaks, could you please move to the back? Promise there'll be food there as well as at the beginning. And so that it avoids congestion so that people can move through. Your staff will be asking you to move through at the same time. If you've got dietary requirements, they'll be at a station on the left of the entrance hall as you come in. Just a reminder about the poster blitz. People have put a lot of effort into those posters. Please go and have a look at them, as well as attending the exhibitors. And don't forget the lunch and learn sessions. This conference is utterly committed to the longevity benefits of the Mediterranean diet, so make sure you look out for the ice creams, popcorn in the exhibition hall. There is some fresh juice as well, I'm told, but you should be eating whole fruit, as you know. Coffee carts are open in the exhibition hall outside the RMA22 Wellness Centre before the plenaries and during the catering breaks. You can make connections through the conference app. You can opt in to sharing your email address, but you need to enable the privacy settings on the app. And if you are like me and have got no idea what you're doing, talk to the registration desk, and they will help you. Some great prizes are already being snapped up with gamification on the app, and don't forget to be involved and claim some great prizes. Our first speaker in this plenary session is the National Rural Health Commissioner, Dr. Ruth Stewart. Ruth is the second National Rural Health Commissioner for Australia. She was appointed in July 2020, presumably remotely. And of course, as many of you would know, Ruth brings 30 years of work as a rural generalist and has the advanced skills of a GP obstetrician. In her career has been devoted to the quality of rural maternity services and sustainable models of rural healthcare. Ruth and her husband Anthony Brown now live and work in Roma, and please welcome Ruth Stewart.
Well, hello. So I'm going to talk to you today about developing the strength to do bold things. But I'd like to begin by acknowledging the Ngunnawal people, who are the traditional custodians of this land on which we're meeting. And I pay my respects to their elders, past, present, and emerging. I do like the way you say it, Norman, that the emerging elders are actually the most important for us here to carry on the traditions. I extend that respect to all Aboriginal and or Torres Strait Islander people who are here with us today. You are most welcome, and I acknowledge that you have overcome many barriers to be here. Thank you for that effort. Now, couple of disclaimers at the beginning. My office is an independent statutory office created under Part VA of the Health Insurance Act of 1973, and it was amended on June the 30th, 2020. I'm telling you that because I'm going to tell you my personal opinions, and they should not be taken as any form of coded sign about government policy. These are my personal opinions, and I'm the one to be held to account for them. Okay? So, I'm going to quote Niccolo Machiavelli here. All courses of action are risky. So prudence is not in avoiding danger, it's impossible, but calculating risk and acting decisively. Make mistakes of ambition and not mistakes of sloth. Develop the strength to do bold things, not the strength to suffer. And that's my challenge to you today. Okay, so we have for many years been talking about the need to establish equity for rural health. But I think we have at times struggled to work out what the steps are to get there. I've got some ideas, and this talk is about those ideas. So, I'm going to begin with funding, talk about models of care, talk about workforce. When we combine all of those things and get them working together, we can get this thing called rural healthcare cooking. And when we get it cooking, we can then get equity for rural health. Let's talk about funding to start with. So currently, health funding is directed to general practitioners and professionals linked to them via Medicare, and to hospitals via state and territory funding through the COAG agreements. Now, I probably don't need to emphasise to this audience that where there are neither GPs nor hospitals, you just don't get much access to healthcare. So the funding that we currently have is failing many of our rural and remote communities because it's not designed for us. What I want to see is a dedicated rural health fund where we get a bigger slice of the pie. So my goal is that we reduce the complexity of funding for rural and remote health and increase the equity of rural and remote health care funding. My dream is that we should have blended funding for mainstream rural and remote health care, and that's blended funding for primary, secondary and some tertiary levels of care. Now, actually, when I say some tertiary levels, I'm talking about linking in to the major centres, the tertiary hospitals, either via telehealth or via retrieval, and making sure that that is seamless and it is funded. Okay? So next, I want models of care. I show this slide quite often. That's a farm gate. Now, Bruce Chatter tells me he came up with this idea first. Good on you, Bruce. But the farm gate, farmers have a problem. They need a hole in the fence that they can open and close at will. And when it's closed, it needs to be really properly closed. And when it's open, it needs to be wide open. Now, farmers could sit and wait for a gate to be delivered to them from, from Brisbane or Melbourne or Sydney or Canberra. But they don't, do they? They make one with what they have available. Now, I think that we need to be creating models of care in the same way, making the model of care that suits our community, suits our gap in the fence, making it with what we have available. So my goal, co-designed by community and health services, using what is available locally to provide the necessary care. My dream is to have networks of multidisciplinary teams of rural generalists, and that's rural generalists in medicine, nursing and allied health, in place-based models of care, responsive to community need and giving accessible care. Accessible care means not just the care that is locally available, physically accessible, it's also culturally accessible, something that fits within the culture of the community that it serves. And you will all know that that isn't always the case, particularly when we have a model of care that was designed in an urban environment and we are told that is the gold standard and this is what we must do in rural and remote. Okay, so in June this year, my office ran the Ngayaba Gadan, which is Yidinji for Coming Together, summit, and we discussed multidisciplinary team care. From the discussions of all of the key stakeholders who were there, we have created a draft consensus statement, and we anticipate that soon we will have the final draft of that, and we will be seeking endorsement from the key stakeholders in rural health very soon. And this will offer a definition of what rural and remote multidisciplinary team care is and what it can do. And that will help drive policy for model of care design, and it will stop the ambiguity that actually currently exists, I hope. That's my dream. So, next, workforce. Rural generalists, really. I don't think I can say that enough. I love this photo. It's a group of rural generalists from both Marlo Coates is in the middle of that, and two rural generalist paramedics flanking him as they wait for the retrieval chopper to land on the Thursday Island Hospital helipad, and the sun sets in the west. So my goal is that we should have a national rural generalist program for training pathways for medicine, nursing and allied health professions. And my dream is that we should have networks of rural generalists working across rural and remote Australia in multidisciplinary teams and local place-based models of care. Okay, how do we get there? We increase rural origin student selection, we increase rural training and placements during the training. We articulate training pathways from the vet sector into universities so that those people who, when they were a teenager in a rural community, didn't see themselves as academic and chose to get a local job and realise now that they actually want to do something a bit more than that, give them a pathway. And we need to increase Aboriginal and Torres Strait Islander health workforce to parity with their presence in our communities. I would love to see a day where in any given community, the health service has an equal representation of Aboriginal and Torres Strait Islander health professionals that community has. So in those remote communities where there's a very high percentage of Aboriginal and Torres Strait Islander people, there is a very high percentage of health professionals who are Aboriginal and Torres Strait Islanders. So we want more generalists. The actions are implement the National Rural Generalist Pathway, recognise rural generalism as a specialised field within general practice. We're well on the way with that. We want equal pay for equal work. When you as a rural generalist do the work that in the city may be done by a specialist who is paid a specialist fee, when you do it in a rural community as a rural generalist who has the skills and training to do so, you should be paid at the same rate. And we need to develop a national rural and remote nursing generalist framework. We're well on the way with that. And increase rural allied health generalist pathways. Okay, so rural healthcare. What do I mean by rural healthcare? I referred to this, but I'll just refresh. It's primary healthcare, it's secondary healthcare, and there's strong links to tertiary care and retrieval services. We do not separate these out in rural and remote communities the way they do in the cities, and our funding, our models of care need to recognise this. So, how do we develop the strength to be bold? Well, now is the time, really. There's an appetite for change. The COVID pandemic has demonstrated that health systems and policy can be changed rapidly and responsively. We know it. So now is the time. Now, just in case you're thinking, what is equity for health? Equity for health is when health outcomes for rural and remote people are equivalent to the health outcomes that people experience in metropolitan centres. Equal life expectancy and equal burden of disease. We are a long way away from that at present. Okay, so those are my ideas of how we might create equity for rural health. And we just need to develop the strength to be bold. Thank you.
Thanks, Ruth. Let's just talk about the rural generalist pathway. Do you have an implementation plan?
No, because the standards for the rural generalist program are set by each of the colleges. We're here at RMA. ACRM has the implementation plan.
No, that's the training. I'm talking about implementation system-wide of integrating it into the system, more rural generalists coming to the pathway, everything that needs to be done. There's a whole series of actions that need to be taken independent of the colleges. Do you have an implementation plan for that?
Yeah, you put me on the spot, and my honest answer is I don't have a piece of paper that I can hand you with a plan. We have the National Rural Generalist Pathway Strategic Council that oversees and has a work plan, but I don't have a plan. It's a good idea. Thank you.
Well, I mean, you can have a strategy. The strategy will go nowhere unless you've got an implementation plan.
Yeah.
If you were to have an implementation plan, what needs to be on it?
Well, so recognition, so that each jurisdiction understands what it is that they're dealing with. We need to have an established program in each jurisdiction because we are a federation, and each of the jurisdictions controls the training jobs in the hospitals. That's not a federal thing to do. So in my role, I'm coordinating and encouraging.
So
along the
doesn't
way.
there need to be targets, hard targets that everybody knows about?
Yep, and those so the targets about the number of rural generalists?
Yeah, and going up. I mean, for instance, the John Flynn's, I mean, there's only 250 FTEs planned for 2027, 160 FTEs at the moment. That's not much growth, for example, just in the John Flynn's.
Yeah.
We've got kind of stalled on single employer?
I would like to see at least, my goal is that there would be at least 1/3 of general practitioners trained would be training for rural generalism. That's my goal.
That sounds like a good goal. What about the single employer model? That seems to be a bit stalled as well at the moment.
I actually wouldn't say it's a bit stalled. We have the Murrumbidgee model. There's strong interest from the government in the single employer model.
What's your office doing about that?
Supporting and encouraging the department and the government to investigate all opportunities to implement single employer models.
I remember talking to Paul, your predecessor, and having the same sort of conversation. It strikes me there's something fundamentally flawed about the National Rural Health Commissioner role. It makes governments feel better, but you don't really have any power.
Yeah, you're right. I don't have any power. I can't say to anyone, this is what you'll do. Apart from my own staff, I can tell them, please, will you prepare, this document for me? But my role is one of influence and to speak truth in the halls of power, really. I'm independent, so I can and do talk quite directly to both the department and there are members of the department here who would attest to the fact that I don't necessarily say the things they want to hear.
Sure. But let's take as a comparator the mental health commissions. You've got National Mental Health Commission, you've got state mental health commissions. Mental health is still in a mess, high priority area. Rural health is still a high priority area. You've outlined an ambitious target there. Western Australia has a mental health commission they're the commissioner. They've got a budget, they commission mental health services. Should there be a national mental health commission with a budget?
Rural Health Commission.
Rural, with a budget that you are commissioning and you can direct.
I would be very pleased to see that as a legacy for my office.
So you need help from RDAA and ACRM to push for that?
Thank you.
I mean, it just strikes me that you can have the best intentions of the world, and there are a few people more experienced than you in the area, yet you're kind of hamstrung by the fact that there's just dotted lines everywhere, and you can't pull any strings.
Yeah, that is indeed the case. I can talk and influence, but my power is that of influence.
So, what single thing could the Commonwealth do to accelerate the rural generalist pathway and get it implemented at a faster pace?
Increase the number of training positions that are dedicated to rural journalism. Increase the insert into the next National Health Reform Agreement requirements of each jurisdiction to increase the number of internships that are in rural and remote hospitals. That would be a very powerful and quite rapidly impacting change.
Now, you've got a strengthening Medicare task force out there with the good and the great on it, not necessarily full of people who are actually committed to reforming Medicare. The general conversation is Medicare is broken, not fit for purpose, particularly not fit for purpose in rural and regional and remote Australia. What needs to change in Medicare?
Well, Norman, I'm a member of that and I've signed a confidentiality agreement.
Right. You can't nobody will talk, just tell us.
What I can say is that given that Minister Butler established that committee as one of his first actions as Minister for Health, I think that signals very clearly that this is a government that is committed to reforming Medicare. And I have been encouraged by the discussions and the content of the meeting agendas. But it will be the government's decision. I'm an advisor. I advise the minister to assist in the creation of policy to improve the health of rural and remote Australia. That's my role under the Act.
I just found a question, and you talked about multidisciplinary teams. I mean, of course, and that's what one absolutely has to have, not just rural and regional, but metropolitan as well. What's happening with rural generalism and nurses? There seems to be a lot of confusion in that area.
So, Deputy Commissioner Shelley Nolan has led a body of work establishing the Nursing Rural and Remote Generalist Framework, which sets groundwork really for the development of curricula for training of rural generalists. There's been really strong support from right across the nursing sector for that framework, and I see that as the first step. So, yeah, it's starting.
Good. Please join me in thanking Ruth for running this today. Thank you. And now it's time for the RDAA presidential address, and from Megan Belot. Megan is a rural generalist doctor from Victoria, president of RDAA, currently works as a GP anaesthetist and VMO at Echuca, and a GP anaesthetist at Kahuna Hospital, and as a GP at the Northern District Community Health Clinic at Kerrang. Please welcome Megan Belot.
Before I start, I'd like to acknowledge the traditional owners, the traditional custodians of the land on which we meet today, the Ngunnawal people, and pay my respects to elders past, present and emerging. And I'd also like to extend that also to the Yorta Yorta people and the Barat Barat people where I work and live, and also to the Warlpiri people of Larjamanu and Kalkarinji that I got to have student placements and resident placements at. I'd also like to pay my respects to the Aboriginal and Torres Strait Islander people in the room here today with us. I just have to start by saying how exciting it is able to come together in person after a 2-year break of RMA. It's quite nerve-wracking for me to be speaking to actual people and not just a screen. So let's see how this goes. Back in 2000, and last time I was here in Canberra standing on a stage, it was 2016, and I was receiving my Akram Fellowship from the current president of the time, who was Ruth Stewart. So it's quite special for me to be here to follow her as for her to be the Rural Health Commission and for me to actually be the RDAA president. Okay, so this morning's theme is bold. That is perfect because we need to be bold. We need bold change to elevate general practice, rural general practice, and rural generalism to be recognised for the premier careers that they really are. For too long, we have relegated our specialty of generalism to something less desirable than other, highly subspecialised and hospital-based fields. We have accepted poorer conditions, reduced rebates, and in general have many of our city-based colleagues looked at us as if rural general practice or rural generalism is something that you end up doing when you can't get into another specialty program. It feels like rural non-GP specialists are seen by their city colleagues as less aspirational, that they are happy to be limited by their rural career and generalist skill set and are not interested in college politics or achieving excellence in increasingly narrow field. But we choose this. We choose this because it's exciting, varied field of practice, that it allows us to extend our scope of practice into a vast array of areas that our city-based colleagues could never dream of. Working rurally gives us access to the large array of patients in the widest variety of settings and complex needs that extends us as doctors as we do our best to keep our patients in their communities with their family and friends as we treat their medical conditions. The degradation of rural medicine as a whole needs to stop. At all levels, from medical school, junior doctor years, registrar years, right through to becoming a fellow. But also in the Department of Health and at government. And I'm calling it out. It needs to stop. We are constantly learning, growing and building our clinical courage in order to meet the needs of our communities. This is the definition of bold, as Dr. Sarah Chalmers mentioned yesterday. That is being bold, bringing bold into our work every day. And we need to make bold changes to protect that, to ensure a bright future for rural medicine, medical care, and to ensure that our rural population have healthcare they both deserve and need. For the past few years, RDAA have been focusing on working towards this bold reform that will see more doctors choosing rural, more GPs, more non-GP specialists, and definitely more RGs. We have presented our rural medical workforce plan to the highest level of government, and it was well received. It is ideas from that document that have formed the basis for recent changes and election commitments, such as the tiered WIP payments that recognise both the quality of care and rurality in which it is provided. Hearing from the former Health Minister Greg Hunt yesterday, there is definitely a sense of unfinished business on his behalf of wanting a 10-year plan for rural health. We have also had some disappointments along the way, such as Labor's government's changes to DPA. And we all know the effect this will have on many rural and remote communities. We warned them from the get-go, and were definitely not silent when it was formally applied. However, we do know that it wasn't a great policy anyway, so we are focused on better, positive workforce reform to actually attract doctors who want to work rurally and have the skills to do so. I guess I'm just disappointed it feels like we've taken a step back. We need to make bold changes towards changing the culture in rural medicine. We shouldn't expect our doctors to remain in a community for 30 years or more. It's great if they do, if they want to. Not to be on call all the time and to have no work-life balance. To do this, we need more doctors, particularly those in M 4 to 5 and beyond, to make the workload sustainable. All doctors, both male and female, should have the opportunity to be part of their family and friends' lives. To do this, we need more time away from work, so better rosters, entitlements, such as paid parental leave. We got a small win for this in last year's budget, where they made changes that would ensure that women who were the primary wage earner in their household became entitled to the government's paid parental leave. These women were previously excluded. Yes, this isn't as much as they were earning at work, but it's a hell of a lot better than nothing that they were getting before, so we'll take it. And we'll keep pushing for more comprehensive change towards better working conditions for GPs to address the inequity in the future. Let's face it, it's very hard to swallow when you're on maternity leave with minimal pay, but your rural other specialist doctor in the same rural hospital is being paid. Is this not the defining disparity and inequity between all general practice and other specialties? To me, this is the first thing to fix to elevate general practice, rural or not. But I guess we also have to look at where we've come from. We're no longer, locking our children up in a laundry cupboard so the professor doesn't see them in medical school, which was only 40 odd years ago. So the culture is changing. We shouldn't be looking for role models in the doctors who work hours that are unsustainable for most of us. Our role models should be those fantastic clinical leads who build great teams of rural doctors to ensure that they are all have a good work-life balance. There are plenty out there, and I, for one, would like to hear more about what they do and how they do it. We need to look at other industries who have made substantial changes over the past few decades towards ensuring that the hours worked are safe for all, instead of expecting them to go above and beyond until mistakes are made. This is important for the safety of our doctors and our patients. Nurses have limitations on how many hours they can work before they get a break. Pilots too, truck drivers. And yet somehow it still seems okay for a GP to be on call for the hospital 24/7, as well as seeing patients in their practice all day, and then the next day too. There is no red light to say this GP has seen too many patients, is probably exhausted, but let's face it, it's taxing work relating to people all day, and not only needs to stop consulting, but they should not be popping up to the hospital to see those in ED either. We need packs of RGs to ensure the rural communities have a sustainable model of care to ensure their sustainable future. After reading some books and obviously speaking with other colleagues around surgical training, this is something that the metropolitan medicine and surgery should take on board too. And while they're at it, stop the degradation of rural medicine and also that of general practice. Telehealth can play an important part in this, because when used in conjunction with a healthy medical workforce, it can take pressures off after-hours care by dealing with less critical presentations, as well as extending the level of care available locally through the access to remote specialist consultations. But it is not and should never be considered a replacement for doctors on the ground. A telehealth consult in a local hospital won't save anyone having a heart attack. You need the local RG to come in for that. Hopefully, if they haven't had to come in 2 hours beforehand for that migraine that presented in the dead of the night, they will be fresh and ready to perform at their best. It should support doctors in the community, not replace the doctors in community. We need to work on the colleges to make bold changes to support more training of non-GP specialists in regional and rural areas. This does not have to be siloed in the metro hospitals. It is exciting for me to see this in my local area with our first ONG registrar in Bendigo. They will get to do all of his training there. Bendigo has also done a great job of attracting and retaining surgeons after offering them a fellowship year. I believe it's 6 out of 10 have remained. But the issue is that this needs further STP funding. The big ticket item in GP land, of course, is transition to college-led training, which takes effect from the 1st of February 2023. RSC GP registrars have an exam just days later, and we need to ensure all registrars from RSC GP and ACRM are supported. ACRM has gotten a head start with New South Wales and Tasmanian registrars already transitioned to ACRM. Congratulations must be given to the one and only CEO ACRM, Marita Cowie, and Dr. Sarah Chalmers, and the ACRM team for their great work on this. Over my next year as President of RDAA, I am excited to be continuing to work towards bold changes for rural medicine. This has already started with RDAA convening the Specialist College Rural Stakeholder Subcommittee, which is in collaboration between Council of Presidents of Medical Colleges, CPMC, and RDAA. It is currently chaired by the amazing Dr. Sarah Chalmers as the only president of a rural college. We will be working hard on keeping the pressure on for the full implementation of the National Rural Generalist Pathway, which includes the single employer model and the tiered WIP. We should see announcements and investments on this in the upcoming budget on the 25th of October 2022, so watch this space. But it was very pleasing to hear from Brendan Murphy yesterday when he mentioned this in his speech. We are happy to see that we got an increase in the John Flynn Provocational Program, and at budget we will see 250 full-time equivalents, which is an increase from 110 from 3 years ago. But we still think there needs to be more done for rural, and our target is 400 FTE. But to continue to up the ante in training, there also needs to be greater support for supervisors who need more money for what they do, but also reduction in red tape and duplication to access funding support. We are continuing to push for support for simple changes that would make a huge difference with the department, with the pollies and the colleges. Supervisors and mentors are a vital part of any doctor's training. We have all had supervisors in medical school, junior doctor years, registrar years, and then until you become a supervisor yourself. And I'd like to share you with a pivotal moment in my career when I realised I'd be able to have the confidence to do more critical care medicine, and that sparked my ambition of becoming a GP anaesthetist like those I had witnessed in Bairnsdale on my internship placement. I was a resident in Darwin, PGY2. I had a particular doctor vet me to fill an RMO relieving job in the ICU and HDU. Her comments were, "You've been to Catherine and survived, and you seem sensible." I got the job. The late Colonel Dr. Sue Winter, CSC OAM, was instrumental in my perception of women in medicine. I saw a doctor with great clinical courage built over years of being in the army, serving in Rwanda, and being one of the 2 doctors who were first flown to Darwin, this time 20 years ago, for the Bali bombings. I saw a confident, take no bullshit, own your place ICU anaesthetic consultant who had a husband and a child and a life outside of medicine. Wow, this is real. I learnt a lot from Sue and am very grateful to have had her come into my life, and grateful that she never discouraged me from being a GP anaesthetist, but encouraged me. Supervisors come in all forms and impacts us on whether it is in our junior doctor years or our registrar years particularly. The impacts can be negative ones, but I want to focus on the positive impacts a supervisor can have. Know supervisors here in the room, whether you're in general practice or in the hospital, that you are important and you need to be valued, and I see you. I don't want to take up any more of your time. We have a fantastic program and we're all keen to get on with it. Just know that RDAA has your back. Our team works tirelessly towards better outcomes for rural health. We are pushing for bold change and we have been making good progress. Thank you.
Great address. Thanks, Megan. Our keynote speaker in this session is Trudy MacDonald. And Trudy's going to talk about an issue which causes heartburn, significant gastroesophageal reflux, I think, in a lot of rural practitioners, because you probably didn't sign up to be managers of people, you signed up to be a clinician. Trudy's an established business leader and human resource professional, and really is devoted to helping people get the best out of your people. Trudy's the founder and managing director of Talent Code HR, and passionate about improving the performance of organizations by creating high-performance cultures and developing leadership capabilities. Now, at the end, we're running a little bit late, but we will take some questions at the end. Could you use your app for that? If you go into the app and you go into the session, you'll see live Q&A, and I'll pick that up on my phone and ask the questions accordingly. We'll probably get through more questions that way. Please welcome Trudy.
Good morning. It's a pleasure to be here, everyone. If you are struggling with attracting talent into rural and remote medicine, if you are struggling to retain your current talent, or even just to keep your current talent motivated, you are absolutely not alone. These are particularly challenging times that we're in. What I've prepared for you this morning is to share with you, number one, how the mindsets of our people have changed during COVID, and what does this mean for the attraction and retention of talent. Number two, I want to challenge your thinking and share with you some really practical ideas around things that you can take back to your organisations that will help you better attract talent. And finally, I'm hoping to share with you some insights from practitioners that I've spoken to personally in preparation for today, to give you some insights as to what's going on in the minds of people that we're wanting to attract and retain. So let's have a look at the current situation so we've got some context. COVID changed our mindsets. It forced us as individuals who are engaged in workforces to really challenge what we value in life and subsequently what we want from our experience in the workplace. Now, there's a number of different terms that many of you may have heard in the media. It started early this year with what was dubbed as the Great Resignation. And this was off the back of some of the trends that we were seeing in the US and the UK. We started to see this very clearly from January this year. Particularly, people were saying, you know what, I'm done, I've had enough. I've been working hard, I'm exhausted. There's more to life than turning up and working long hours every day without the balance that I'm looking for. I'm going to look for something else. Now, there's been a huge amount of pressure with salaries in the market as well, which has made that particularly enticing for people. As we track forward a few months, what we then started to see was a term referred to as the not so great resignation. And specifically what many organisations started to see is that people were leaving. However, once they got to the other side, they realised that it wasn't necessarily greener over there. In fact, if I've been offered more money to go to a different location, the expectations of me are even greater than what they were before. And that's certainly not what I'm looking for. The other thing that they started to realise is that all of the non-financial benefits and perks that came with my role, maybe I took those for granted previously, and they're not necessarily available to me in the current workplace. So we started to see this boomeranging happen, where many organisations had people saying, well, look, I left 3 months ago for a large salary. Is there any chance that I could come back? So interestingly, that then led us to those stories becoming folklore and people starting to recognise that, you know what, it's not necessarily going to be greener on the other side. We then shifted into a period of time referred to as the Great Renegotiation. And what that meant is people said, you know what, I'm going to stay where I am because it's actually not that bad here now that I think about it. However, I'm still not happy. I'm burnt out, I'm exhausted. So I'm going to start negotiating with my current employer for better conditions, for more pay, or specifically to start to move away from what we all traditionally viewed as traditional employment, working 5 days a week, working long hours, working a lot of overtime, and everything else that came with that. Where we are right now today is a term that you may have referred to as quiet quitting. And what that means explicitly is many of our team members are showing up to work and they're exhausted. They're burnt out. They've lost their mojo. There's no energy left. They are going through the motions. But what we don't have here is what's referred to as discretionary effort. And what that means is it's putting more pressure on organisations, and ultimately people are not getting the job satisfaction that keeps them going and keeps them doing the great work that they're doing in rural and remote areas. So what's the big picture here? The big picture is nothing new, but it's worth reflecting on what's going on here. Ultimately, we need our people to be engaged. So what does engagement look like? Engagement looks like I jump out of bed in the morning, I've got energy, I'm excited, and I'm looking forward to going to work today, versus disengagement, which is I wake up in the morning, big sigh, here I go again. It feels like Groundhog Day and I'm absolutely exhausted. Now, the statistics around this are pretty scary. Only about 20% of the world's workforces are considered to be engaged. Now, this is really interesting when it comes to retaining talent. If we want talent to stay with us, engagement is critical, because with engagement, you also get loyalty And what that means is, you know what, I'm going to stay in this rural area because I'm so connected to my employer, to the people that I work with, to my community, that I'm not going to look to go anywhere else. The flip side of everything I'm going to share with you today is if we can understand what people are actually looking for from their experience of the workplace, we can use that as an attraction tool. And one of the interesting themes here is that many people, as we know, are looking for a tree change. So in rural and remote medicine, we've got an enormous opportunity to tap into what people are looking for because there's actually a shift towards rural and remote areas. What I wanted to share with you is some current research. This research is only 8 weeks old. It's come out from McKinsey. And what it's done is it's looked across all industries to ask individuals, what is it that's having them stay with organisations? So what are the drivers of retention? But then also, why would people leave their organisations to go and work, for example, in a rural and remote area? Now, in order to validate this research, and it is a very small sample size, I did some of my own research. So I've spoken to a number of junior doctors, to specialists, to allied health professionals, and I've asked them 2 very focused questions. The first is, what would it take for you to consider working in a rural and remote area? And the second question is, what do you love about your current job? Why are you staying where you are? Now, it's interesting if I refer you back to this research for a moment, and the numbers on the side represent the percentage of individuals who said, these are the key reasons why I would either stay or leave an organisation. Money is number 1. In my entire career, I have never seen remuneration as the number 1 reason why people would leave or stay at organisations. It usually sits at about number 5. So what's going on here? And I think this is really interesting for all of us to understand. The psychology around how we think about remuneration is as follows. If I perceive, and I'm using the word perception very deliberately, if I perceive that I am paid fairly, money is not going to be an issue for me. It's off the table. And in fact, all of the other things that you see up there are going to make a difference around why I stay or what's going to attract me into rural or remote medicine. However, if I perceive that I'm not paid fairly, it's all going to be about the money. Now, when I spoke to one of the junior doctors and asked her the question, what would it take for you to work in rural and remote medicine? The first thing that came out of her mouth was money. And I got curious. I said, tell me more about that. What do you mean by money? Surely you're on a decent salary, and surely you can see you've got a good career trajectory and you're going to be earning more money over time. She said, absolutely, Trudy. She said, but here's the thing. There is an assumption in medicine that I'm in this career for altruistic reasons. And she said, you know what? I am. I absolutely am. I want to make a difference. I want to help people. However, when that's used as an excuse for not paying me fairly, then it becomes an issue for me. And as I dug a little deeper, the specific example she gave me, she said, look, I work a huge amount of overtime. And when I have to go to my directors and continue to beg and ask to be paid overtime, that is not fair. I just want to know that I'm going to get paid fairly for the hours that I'm doing. Now, when we talk about perceptions around money, it's interesting because there's so much noise in the media at the moment that you can earn more money, and I've got private practices competing with government organisations. One of the most important things that we can do is, number 1, understand what the markets are paying in your particular areas. Secondly, proactively communicate to either your applicants or your current staff that we are paying fairly so that they understand what the reality is versus the perceptions that they're hearing from others. And number 3, make sure that they're remunerated fairly for the outputs and the contributions that they're making. So let's put money aside for a moment, because you can see that there's a number of things up there that are actually more impactful once we get money off the table. And the key one that I find most leaders and managers struggle with is this concept that I'm looking for meaning and purpose in my work. Now, we're working in an industry where people want to make a difference, and that is going to create a sense of meaning and purpose. However, through COVID, our definition of what that means to us has shifted and it's become much more personal. So I'm going to give you some tips shortly around how you can tap into meaning and purpose and actually use that as a real point of differentiation when you're looking to attract talent into rural and remote areas. But let's talk about this piece around workplace flexibility. One of the other medical professionals that I spoke to, she said, you know what, I want to know that I will be treated and valued as a person. I said, okay, tell me a little bit more about that. And she said, well, this is the thing. I've got a life. I'm a person too. And I don't want to be made to feel guilty if I have to walk out of the practice or walk out of the hospital because I've actually got to go to the bank. I want to know that I've got the flexibility and the trust and the autonomy to deliver on what I need to do, but I've got that trust that I can also have a life as well. So there's some really simple things that we can do here. And if we can get these right, it actually creates a unique point of differentiation for our organisations, which will enable us to tap into attracting and retaining talent. So what I'd like to do now is delve into 4 of the areas that I'm finding most organisations are really struggling with and give you some really practical tips around things that you can do. The first one is that organisations are recognising that their professionals are looking for a high support environment, an environment whereby I feel supported, that I'm not burning out, but I also feel supported in terms of me as a person, my entire life. And something that COVID did for us is it removed this traditional perception that you don't get too close to your people because you may have to performance manage them one day. In fact, we're now in an environment where we need to be closer to our people than ever before because COVID invited us into people's lounge rooms. We saw their kids, we saw their kitchens, we saw the courier turn up at the front door. We now are engaging with our team members as human beings, as people. And one of the things that we need to get right is delivering a level of support so that they can continue to deliver the great work that they want to deliver. What I've got here for your consideration is a model of what it means to be a high-performance team or be operating in a high-performance environment. And ultimately, that's what we're looking for. That's the objective of our organisations. The model that you can see here shows that we need an appropriate balance between challenge and support. So let me give you some context around what that means. When we think about challenge, I'd like you to think about challenge at an organisational level. Where is your organisation going? What's the direction? What's the strategy? What's the plan? And, this is the key element, what's in it for me? Nobody wants to work for an organisation that's not going anywhere because the assumption is, I've got no future either. The second element of challenge is at a team level. So what are we doing at a team level with our multidisciplinary teams, if that's the case, to deliver on what we need to deliver? And are we challenging each other? Do we have goals? Do we have scoreboards? Do we know how we're tracking? What are the metrics? And are we using that to build the energy? And then finally, what does challenge look like at an individual level? One of the things I've noticed in the last few years is that we've stopped holding people accountable. Now, why has that happened? Because we're scared that they might leave. Now, the problem when we don't have a culture that's rich in accountability is the pressure goes on to everybody else. And I've seen this a lot with leaders and managers in the last few years. Because people are burnt out, they're exhausted, we don't have enough staff, many leaders and managers have rolled up their sleeves with good intentions and they've dug in and they're helping out the team. But the problem is we've got what's called role compression. And what I mean by that is not only am I doing my role, but I'm doing parts of other people's jobs as well. Our roles have been compressed, and as a result, we're feeling exhausted, and it's becoming stressful. Now let's think about support. Support occurs at those 3 levels as well. What does support look like at an organisational level? What are our policies around flexibility? Do we have employee assistance programs to support our staff and their families when they've got challenges that they're dealing with? What does support look like at a team level? Are we truly operating as a team where we will do almost anything to help each other out and we feel connected as part of our team? And then finally, what does support look like at an individual level? So when I've got young children at home and they're sick, is there an approach for me to be able to possibly work from home? Or is there flexibility for me to go to my child's concert at the end of the term? Or am I made to feel guilty because I'm not here helping people and doing my core job? What's really interesting when you start to think about those dimensions, and hopefully you're thinking for your organisations, how well do we do these things, is most organisations across Australia really doubled down on support during COVID, more so than ever before. However, the challenge got greater and greater, and rural and remote medicine is no exception when it comes to the challenge. Subsequently, many organisations identified that their teams had dropped from that purple zone down to the blue zone. Things were becoming more and more stressful, and that was accentuated by people leaving and people having to work multiple jobs just to keep the wheels turning. Now, with all good intentions, what I then saw many organisations do is pull back on the challenge, because they said, our people are exhausted, we just need to pull back a little bit here so we can sustain what we need to do. What this resulted in is where many organisations find themselves today, which is they've jumped into the green zone. Many of you may relate to this, where we have created a huge amount of support for our people. However, we've pulled back on the challenge. Now, I'm not talking about doing the day-to-day work, because that is undeniably exceptionally challenging. I'm talking about the other things that we should be doing in our organisations to continue to move forward, to progress, to grow, to innovate, to better serve the communities that we're part of. Subsequently, many organisations are looking to do a reset, and specifically the strategies that they're using is, how do we reset? How do we look at how we're going to go forward? How do we revisit our ways of working so we can subsequently create an environment that puts us back in that high performance zone? One of the key messages here is that accountability and challenge is not punishment. It's actually what people need to be motivated. We love working towards meaningful goals. We just need to make sure that the support is there to balance that out. As we start to look at how we can manage this within our organisations, it's critical that we establish guardrails. And when I talk about guardrails, what are the principles by which we will deliver support and create an environment that's going to have people stay with us, but also will create a really attractive environment for people to come into rural and remote medicine? One of the most practical things that I've seen organisations do is to create some guiding criteria around those guardrails, and specifically then empowering teams to actually make their own decisions around how they're going to operate within those guardrails. 3 very powerful questions when you start to consider practical things such as, is it possible for me to work from home 2 days a week or not? Is it possible to have flexibility around my work hours? Is it possible for me to just work 3 days a week and actually not be employed on those other days? And these are the kinds of non-traditional ways of thinking that we really need to get our heads around. The current research shows that about 44% of people expect that they won't be working for their current employer in the next 3 to 6 months. Pretty scary. Of that 44%, roughly half of them are moving to non-traditional employment. That's what they're looking for. Now, what does that mean? It means that I either want to work part-time, not full-time anymore, or I want to consult. So there's different options here. And what I'd really challenge you to do in your rural and remote organisations is to challenge your traditional models of employment and start to think about, could we employ maybe 2 doctors instead of 1 and give them the opportunity to each work 3 days a week each, for example, so that they can meet some of these other things that they're really looking for that will make it an attractive offer for them. The criteria: does it work for the organisation? Does it work for the team? And does it work for me? And if you can establish that criteria as a framework, it actually gives you the opportunity to think about how could we rethink the way that we create work experiences within our organisations. The other thing we need to think about are some of our personal biases and preferences, the way we've always done things. Now, this won't apply to all roles within rural and remote medicine. However, there may be some roles where we're saying, you know what, you have to be here physically in the workplace, otherwise we can't create a culture. Rather than starting with that mindset, what I'd encourage you to do is to think about how could we create a culture whereby we had people working under different conditions. How could we make this possible? And one of the most powerful things that you can do is look to co-create those solutions with your team rather than putting all of the pressure on yourself. All right, let's move to the second one. The second thing that people are really looking for is an environment where they feel valued and appreciated. Now, this is not new and it's not rocket science. However, we don't do this particularly well. There's a piece of research here that looks at the difference between financial versus non-financial rewards and to what extent that impacts engagement. Now, why is engagement important? Because we get discretionary effort, we get people going above and beyond, and we get loyalty. They're not going to go anywhere. Now, you'll get a copy of these slides later. You'll be able to download them and look at this in more detail. But here's the key message. There's a dotted line that spikes right up, and then it drops quite quickly. What that represents is non-financial rewards. Non-financial rewards are going to give you a greater impact than any amount of money that you can pay people. Don't get caught up in the money. However, as mentioned earlier, we need to make sure that we're paying people fairly. So let's pay them fairly. Let's make sure they understand that. Let's take money off the table, and now let's focus on the non-financial rewards. Now, the best form of non-financial reward will cost you nothing. And this is what it is. It is authentic recognition. It is talking to your people in an authentic way and catching them doing good things. In fact, this should be one of your highest priorities. Now, I'm going to give a model with you to consider here. It's an acronym, SBI. You might want to write that down. Situation, behaviour, impact. When we are recognising people, we've got to avoid praise, because praise can be a little bit dangerous. It can feel inauthentic pretty quickly. You're doing a great job. You're amazing. Thank you. Continue doing your great work. Really appreciate everything you're doing. After a while, it sounds pretty superficial. SBI. Mary, I just overheard the conversation you were having with pathology. I could see that they were quite frustrated because you've been harassing them to get Mrs. Jones' results through quickly. I really like the way you talk them through Mrs. Jones's personal situation so that they got an appreciation of why they needed to accelerate getting her results through. That's such an impactful conversation that you had. Thank you, because I know that this is really important for Mrs. Jones. That's the kind of conversation we need to be having with our people. It is simple, it is free. When I spoke to one of the other specialists as part of my research, I said, what would take you into a rural and remote area? She said, a collegiate environment. They were her words. However, what she's really talking about is a place where I feel valued and appreciated. So here's the question. Do your leaders and your managers, do they have the skills and the focus to catch people doing good things? Because that's going to make a difference for them. The next factor that many people are struggling with is this concept that I need to feel that I'm in a high trust environment. Now, why is this important? It's important because ultimately people want to feel as though they can contribute, that they can make a difference. There's a term referred to as psychological safety that you may have heard of. It's very similar to trust. And what that means is when I show up in this workplace, do I feel as though I can be my authentic self and that I can actually contribute in a way that I can make a difference? There's 4 levels of psychological safety that most of us work through. Number 1, inclusion safety. Do I feel as though I fit in here, or do I need to behave in a particular way? Because if I want to get on around here and not annoy anybody, I've got to behave in a certain way. We need to be able to be our authentic self to get the best out of us. Level number 2, learner safety. In medicine, we are constantly learning. Do I feel safe stepping outside of my comfort zone, trying new things, and knowing that when I make those little mistakes, that I'm not going to be blamed, that I'm not going to be criticised? And maybe it's a different way of engaging with our patients, or maybe it's a different way of even running our team meetings so that we can get more collaboration. Am I going to be punished? Am I going to be made to sound silly and feel incompetent? Or is the learning actually going to be embraced? Number 3, contributor safety. Do I feel safe contributing my ideas to this practice or to this workplace so that we can actually continue to move forward and make a difference and be even better? You know you've got contributor safety when people will lean over their patch into somebody else's patch and say, hey, have you thought about that? Or I was thinking last night that we might be able to do this a little bit differently so that we can better engage with our community. Would you be open to having a chat about that? It's the safety to know that we can do that versus sitting back in our silos and going, you know what, that's the smartest person in the room over there. I'm not going to dare challenge them. Which leads to the 4th and final level, not surprisingly, challenger safety. Do I feel safe giving feedback to my director or my manager? Do I feel safe challenging what another area of my organisation is doing? Now, these are all cultural elements at the end of the day. People will stay at organisations if you've got these factors. Likewise, they will leave organisations if they do not have these factors. Now, there's a flip side to this coin. If you can do these things, it will help you retain your people. If you're looking to attract people, it's worth recognising that this is what they're looking for. So how do we sell this message and communicate in a way that helps people know that our organisation is different? And finally, we're now talking about the concept of motivation and meaning. As mentioned, in the medical profession, most people are doing it for altruistic reasons. However, as I mentioned earlier, it's not enough anymore. So there's 2 key ways that you can look at creating true meaning and purpose for people. Number 1, back to your organisation or your clinic or your practice. Where are we going? And if I can use the analogy that you want your people to get on the bus. If someone's going to get on the bus, the first question they're going to ask is, why would I get on the bus? You need to be able to clearly articulate, this is where we're going. This is our purpose. This is the difference we are making to this community. They're then going to ask you, well, where's the bus going? And that's where you need to be able to clearly articulate your vision. This is what we're actually looking to achieve. They're going to say, okay, I'm on the bus now. I've bought into this. This is exciting. What's the first stop? And what's the next stop? It's the goals. It's the opportunities. Where are we actually going here? And this is the important piece. What's in it for me? What does this mean for me in terms of my career, the opportunities that I'm going to get, and the difference that I'm going to make? So that's the first element. The second and the final element is about tapping into the uniqueness of each individual that you're either interviewing or that you're trying to retain. And there's 2 very, very simple questions you can ask. Number 1, what do you love most about your job? Now, that's going to stump people a little bit because when they deeply think about it, it's probably not going to be the day-to-day things that they do. You're going to hear things such as, you know what, I really love educating the younger people in this remote community because if we can start to get them to better understand healthy lifestyles and practices, it's going to make a difference into the future. Now, if that's the kind of thing you hear, and you'll know that it's authentic because they'll get a twinkle in their eye and you'll see that the energy's there, here's the question to ask yourself. How can I craft this person's job? So this is possibly a new term for you, not changing their job, but craft their job so that they've got more opportunities to do that. Because if that's the thing that's going to have them jump out of bed in the morning and say, you know what, it's going to be a great day, I'm going to do everything I need to do, but I know on Friday I'm going to get to go out to the local school or the local community centre and do some education, you've got me, I'm not going anywhere. And in fact, if you're trying to attract people into your rural and remote organisations, ask that question, because if you can create that deep sense of purpose and meaning, you've got them. The second question takes a little more courage to ask. What does the dream job look like for you? Now, it takes a little bit more courage because you might not like what you hear. However, you are better off understanding what's going on in people's minds and then challenging your thinking around your traditional work practices and asking yourself what's possible, then not knowing and have them leave, which then perpetuates the problem that you've got. In summary, what I've shared with you are a whole range of things that tap into how our mindsets have changed as individuals. If you can bottle that magic for yourself, what you can create is what's referred to as an employee value proposition. The acronym for that is EVP, Employee Value Proposition. And what that means simply is, why would great people want to leave their well-paid job in a metropolitan or a city area and move into a rural and remote organisation and stay with you for the long term? What is it that's going to bring them there? And one of the most powerful things that you can think about here is start thinking about individuals as individuals and challenge your traditional thinking around your work environment and your work practices so you can create a much more personalised experience within the guardrails for everybody that you're looking to attract. So from here, there's a number of things. There's a lot to take on board, and sometimes we struggle with practically what to do and how to do this. We've got a resource guide for you that I've prepared, along with a copy of the presentation and a whole series of videos that will give you some really practical tips. If you go to the conference app, you'll see my bio, and on the very last line, there's a link there that you can see, or you've got the QR code in the presentation. If you simply go to that, you can have access to all of those. With that, thank you, and back to Dr. Norman Swan.
Thanks, Trudy. Quite a few questions have come in on the app. One is, you've got the boomer generation retiring, millennials coming in.
Yeah.
What's your perception of the difference between the two? Is it exaggerated? How do you manage for that? Because that is about what people value and understanding that. So that where that question's oriented.
Yeah, very, very good. So as you've got an ageing workforce, it's interesting, because one of the themes that's emerging is the people that have actually gone into retirement are more open to coming out of retirement if you can create a work experience that works for them. So it's tapping into what's motivating them. And it may be that, you know what, I would love to move out and have a tree change and work in a rural or remote area. And if I could work 3 days a week, and that means that I can still engage in my other lifestyle interests and possibly see my grandchildren that live in that area, then that's going to work really well.
I think this is more about recruitment. You're recruiting a younger generation.
Yeah.
And people talk a lot about millennials.
Yeah.
Are they that different?
Are they that different? They're certainly different from the ageing population, and there's different drivers and different needs. So when we talk about millennials, the thing is the mindset shift. They're looking for much more flexibility. They are not prepared to sacrifice the rest of their life just for their career, and that's now the expectation. So one of the things to think about is that flexibility more broadly used to be a point of differentiation. What's happened during COVID is it's now an absolute expectation, and that's one of the key differences.
There's a flavour in the response that some of the things you're asking people to do are really hard to do in the rural setting. Like you said, well, just employ a second doctor.
Yep.
Most of the practices in this room would like to employ 3 more doctors, not just 2, and they can't even get a second.
Yes.
So what do you do in that situation where you actually cannot offer flexibility?
Yeah. So this is where I want to challenge your thinking, because I recognise...
So have you got to imagine a second doctor, do you, or what?
Yeah. Well, it's a good start. It's all about attraction at the end of the day. If you can create a compelling story around what your experience will look like when you move to this area, you can actually start to eliminate the attraction problem. So for me, it's going back to the root cause, which is we're not creating something compelling for these doctors to move into rural and remote areas. But if we can rethink what that experience can look like for them, and it's actually about talking to your people. So let's assume that you have a doctor apply for your job. Ask those questions. What do you love most about your job? What does the dream job look like for you? And if they say, you know what, the dream job would actually be working 3 days a week, ask yourself, how could I make that possible? And if you've got 2 that give you that answer, how, and it's challenging yourself with the how question, could I bring those jobs together? So maybe it's a shared job, but now I've got 2 people that are absolutely committed and locked in.
Many people in this room also work in hospitals.
Yep.
and then they're in an environment where they don't control it, and often hospital managers are poorly trained.
Yes.
And remote.
Yep.
Not geographically remote, but remote.
Yeah.
How do you, as effectively an employee in the system, change the leadership?
Yeah, yeah. So you're absolutely right, the remoteness of management. And I think what's interesting is we got away with it previously. We're not getting away with it anymore. If managers and leaders are not truly engaging with their people, and these are pretty fundamental elements of what good leadership and management look like, what's happened now is there's a spotlight on that and we're not getting away with it because people are leaving. So we're spending a huge amount of time doing leadership development. These skills are trainable. Training people, how to make people feel valued and appreciated, how to step outside my natural communication style, which is just to lock myself up in the office and get through my paperwork, and actually prioritise going out and talking to my people and understanding what they're experiencing and working with them to find solutions. So it can be trained, and there's a lot of training happening in this space.
Right. Knock on the office door. Okay. Question, which is really an interesting one, which is, somebody, the person in the audience understands what you're saying about redesigning work, recrafting work, and so on. Yeah. In a highly pressured environment with too few staff, I mean, that's almost the norm in rural and regional practice. How do you restructure and recraft without creating the risk of burnout?
Yeah. And this is one of the biggest challenges right now. Most people are experiencing burnout. Let me share with you a framework, because the reality is there's not an overnight fix and there's not a silver bullet. However, if we've got a strategy towards fixing it, then we can actually make progress. And if people can see that change is happening and they've got hope that there will be a difference, then people will stick around. So let me share with you a really practical thing. If you could sit down with your teams that are overworked and burnt out and reflect with them on 4 key questions in the context of their current role. Number 1, what's the great work that you're doing? So work that's actually adding future value to the clinic or to the hospital. Number 2, what's the good work that you're doing? This is the day-to-day transactional work to keep the wheels turning. And then number 3, and this is where it gets interesting, what's the poor work that you're doing? Now, it's not poor quality work, it's work that's a poor use of your time. And I find in every job, people are doing poor work. It's either work that's inefficient, because it's rework, because it's fixing other people's errors, because we're searching for information that we can't put our fingers on quickly, etc., because it's something that I'm doing manually that could be automated if we just used our technology system properly. There will be a list of poor work that consumes space in everybody's day. And then the last question is, what's missing? Now, if you can do that analysis and come together as a team and use that as a framework for discussion, I can guarantee you'll be able to take a piece of poor work out of their bucket. And that's going to create space. And if you can use that as a continuous improvement framework, what you'll find is that over time, you will start to shift people to focusing on the most important elements of their role, and you'll start to remove some of the poor work, because as human beings, we get into habits, and those habits aren't always necessarily good work habits.
I mean, I think it's important to define burnout here, because burnout is not working long hours.
That's right. It's also the
What are the risk factors for burnout?
Yeah, that's right. So there's a number of things. So it can be working long hours. It can be that I don't have a.
I thought there was very little relationship between long hours and burnout.
There is a relationship, absolutely, and I think it's also what else is in my life. So if we think about all the foundations of what it means to have well-being, there's a balance, as we know, and these are the basics of exercise, of appropriate diet, of mindfulness, of being actually to clear our mind out of where we are. But as you're mentioning, the complexity of the work that people were doing will also lead to burnout. So there's really powerful conversations we need to be having with our teams to give them the skills to build their own resilience, but also to create an environment within our teams and organisations where we can create an environment that supports resilience.
And a few of the comments are around inflexibility in pay.
Yes.
Most general practice, most rural practice are operating on very thin profit margins.
Yep.
There's not a lot of opportunity. The principals are getting paid the same as the people who are employed in the practice. Not much difference between the two, and the profit they're getting out of it is not great.
Yep.
And therefore, your flexibility to negotiate on pay is limited.
Yes.
Which I presume puts a huge focus on the other things that you can offer.
That's right. And back to my starting comment, people just want to know that they're paid fairly. So there's two things. The more transparent...
So I'm the principal, I'm paid crappily, you're going to be paid crappily.
Yeah, that's right. And this is how it is out here. But let's put a tick in that box.
Perhaps not the right way to go about it, but yeah, okay.
That's right, we're all paid poorly. I think the other thing, though, and this was, it's a small sample size, but when I spoke to one of the junior doctors, she said, I just want to be paid for the overtime that I'm doing and not to be taken advantage of, because there's a perception that I'm doing this for the greater good. So if we can get those basics right, we take money off the table, and then it's all the other things.
Could you please join me in thanking Trudy?
Thank you.
So that concludes this first plenary. Don't rush off. Morning tea's in the exhibition hall. Remember, move in. Don't clog the doorway, otherwise somebody's going to have a go at you. Don't forget the poster blitz in the foyer. Please visit that. After morning tea, there's 8 concurrent sessions to choose from, and a pre-lunch yoga session in the Wellness Centre. And lunch and learn will be in the exhibition hall. Please join me again in thanking all our speakers today. And I'll see you again for this afternoon's plenary, which should be a great one.